We're going to segue from here into frontline worker safety, where our panelists will discuss the challenges and solutions to maintaining worker safety and maintaining a supply chain during this pandemic. So we're going to hear from Dr. Bonnie Maldonado. She is the Senior Associate Dean for Faculty Development and Diversity and a Professor of Pediatrics and of Epidemiology and Populational Health Chief in the Division of Pediatric Infectious Diseases here at Stanford University School of Medicine. She's also the Medical Director for Infection Prevention and Control and an attending physician at the Lucile Packard Children's Hospital at Stanford. After that, we will hear from Amanda Chawla, who's the Vice President of our supply chain here at Stanford Healthcare, as well as at the Lucile Packard Children's Hospital in Stanford Valley Care. And finally, Professor Itay Shavit, Director of the Pediatric Emergency Department at the Rambam Healthcare Campus. So Dr. Maldonado, let's start with you.
Thank you so much, Mark, for that introduction. Can you see my slides and can you hear me?
Yes and yes.
Wonderful, perfect. I'm going to run through these very briefly. I just wanted to provide an epidemiologic framework for how do we approach this particular disease and how did we look at it and how do we look at it now, very briefly. And so we can lead on to the PPE supply chain issues and then talking about case studies. I'm going to talk a bit about what we know about respiratory versus aerosol, what we know briefly about masks. And as an infectious disease epidemiologist and an infection control director at the hospital, we have to think about things like mode of transmission. And we know that this is a human coronavirus. So we know the modes of transmission of human coronaviruses are primarily respiratory, although there initially obviously was worry about aerosol transmission, and there continues to be worry about that. So we try to take the most conservative approach here. And you can see here in this graphic, when you have an infected individual, you can have potentially transmission from close airborne contact. You can have true airborne contact, and we'll define that in a bit. You can have fomite transmission as well, but you can also have droplet contact transmission, either from the airborne viruses that persist in the environment or direct droplet inhalation. And so you can see here that those are mechanisms that we think about from an infection control standpoint, from patient to patient, family to patient, healthcare worker, et cetera. So these can be bilateral or multilateral transmission mechanisms. And everything we do about infection control measures and PPE is with that taking that into account. But there are other things to take into account as well. So first of all, when we think about respiratory viruses, we think about these major modes of transmission: contact or fomite transmission, droplet, which is really, for an epidemiologist or an infection control individual, we're really talking about large droplets. That is, those that travel through the air from the mouth of an individual and are exhaled onto another person. And those droplets can actually travel quite a distance depending on the force of the transmission of the exhalation of that droplet. So we have seen papers, for example, that have demonstrated that droplets from an individual's mouth or nose can travel up to 13 feet or more than, say, 3 meters. Or more than 4 meters for that matter. So we know that droplet transmission is probably the major mode of transmission of most respiratory viruses. However, airborne transmission is thought to be still potentially on the list of exposures from this virus. And clearly we know that there are other agents such as measles, chickenpox, tuberculosis, and a few others that we know definitely are airborne transmitted viruses. And we'll talk a little bit about what that means. Now, we know that the principal mode at this point epidemiologically of SARS-CoV is through exposure to infectious respiratory droplets. And by that I mean larger droplets, most of which are visible, but not all, which flow through the air and fall rapidly within seconds to minutes. Now, very small droplets can indeed persist in the air for minutes, in some cases to hours, in the case of measles or chickenpox. And those droplets are generally extremely small. We're talking about less than 5 microns, and they are obviously not visible to the naked eye. And so those can actually persist in the air for some diseases that we know have airborne transmission and for which the transmission rates are therefore very high. So airborne transmission, again, as I mentioned, can mean very tiny droplets. It can basically be sustained in the air because they are so small, and can take up to a couple of hours, or sometimes a little bit longer, but really 2 hours is what we think has been documented. Because they are so small, they eventually evaporate and can fall to the ground. However, these modes of transmission are not mutually exclusive. So close contact, for example, can really result in transmission from those very tiny aerosols directly into an individual's face, especially somebody who may be working in an aerosol generating procedure. We also know, for example, that contact droplet precautions are taken for children, at least in our hospital and many others, as opposed to adults, because children can wipe their secretions directly onto their face or their clothing and then wipe them onto an individual. So rather than just depending on droplet spread, they can actually take those droplets off their face and nose and spread them onto others. So droplet precautions can be taken there, which includes gowns and gloves and face shields. So from an epidemiologic perspective, an aerosol really defines these very small droplets, and especially these droplets that can be generated during aerosol generating procedures. And we all know that there are a list of those, including things like intubation and bronchoscopy, that can produce very high numbers of these extremely small droplets that are unseen. And that require engineering controls such as high air exchanges, as well as PAPRs, CAPRs, N95s, and other devices to prevent those very small particles from being inhaled by a recipient. So why do we think that the epidemiology of SARS-CoV-2 indicates that most infections are spread through close contact and respiratory contact and not aerosol? Well, we know that the transmissibility of measles and chickenpox and TB is extremely high. The R naught, or the efficiency of transmission, is on the order of 15 to 20. Whereas we know that for SARS-CoV-2, the efficiency is about the order of 2 to 3. So many, many logs lower than the transmission of those very highly airborne transmissible diseases. We also know that the majority of individuals with SARS-CoV-2, almost up to 50%, may be asymptomatic. So if we had many, many people in the environment who were asymptomatic and were transmitting viral particles in an aerosol format, we would expect to see a much higher attack rate like we see with measles, chickenpox, and TB. And we do not see an attack rate that high. In addition, the evidence for efficient spread through aerosols just has not been found. There have been some case reports of aerosol transmission. And again, those have mostly been in very specific situations. And we know that these events are uncommon and have typically involved the presence of an infectious person producing respiratory droplets for more than 30 minutes or so in very enclosed spaces. And enough virus may have been present for those individuals, who were more than 6 feet away or who passed through that space very soon after the infectious person had left. So existing interventions, meaning masks, distancing, and hand hygiene and deep cleaning, appear to be sufficient so far epidemiologically to address transmission through close contact. However, the other areas that we need to consider are adequate ventilation and avoidance of crowded indoor spaces when you can actually see concentrations of small suspended droplets and particles. And at this time, however, those are very limited situations, especially around times when we are generating aerosols through aerosol generating procedures. And at this time, there's no indication of a general community need to use special engineering controls. It has not been demonstrated epidemiologically to be important. So these enclosed spaces, we do have questions about how enclosed does the space need to be? What is prolonged exposure? That is, we know that 15 minutes has been counted, but Can we use, we know that if people are within longer distances than 6 feet, if they're shouting, singing, exercising, is that going to be enough to provoke exposures? And then inadequate ventilation or air handling can allow buildup. And again, to date, we have not seen major examples of this in the literature. And so at this time, what I just want to leave you with are questions about SARS-CoV-2 that can help us to answer those, that can help us to figure out how to further protect our populations. But I will say that the vast majority of literature, including that at Stanford, indicates that with the current PPE that we are using, that I outline now, that is with aerosol generating procedures around infected individuals and with regular surgical mask distancing and hygiene around those known not to be infected, we have not seen transmission of disease. And that has been the case around the nation and around the vast majority of publications from around the world. That being said, we would still like to know how effective are mitigation efforts to prevent SARS-CoV-2 spread, especially ventilation and masking. For example, it would be nice to know how many air exchanges we need, what kind of ventilation metrics do we need in the environment, and what kind of masks are more efficient than others. What proportion of SARS-CoV-2 infections are acquired through airborne transmission? At this time, we don't have evidence of large airborne transmission events, but we would like to understand that better. What are conditions that facilitate that? We know that aerosol generating procedures are imputed to be that, but we don't know the specific conditions that would it would enhance that. And then what are the infectious doses, inoculum size, and routes of inoculation? And I will just skip this because I know we want to move forward, but we know that N95 masks filter. And this last slide that's showing in a contact tracing study in Thailand of over 50,000 individuals who were exposed, and then looking at whether individuals were infected or not. You can see here the risk of exposure being is on a logarithmic scale here. The risk of always wearing a face mask was 70% protective, whereas sometimes wearing a face mask was not protective. In fact, was as inefficient as not wearing a face mask at all. However, washing hands was highly efficient, as efficient as sometimes washing hands, and then staying in more than 1 meter away from the individual who was infected was also highly effective. So we know that masks are critical, hand washing and distance are important, and all of these point to non-aerosol transmission as the major route of infection. So I will stop there. And here are references that we can post for you so that you can take a look at some of this evidence that I just reviewed. And I'd like to thank you for your attention.
Thank you so much, Bonnie. It's clear that as much as we are learning about this virus, we still have quite a great deal more to learn. Next, we'll hear from Chawla about supply chain issues and how we get the stuff that we need to protect our healthcare workers.
Thank you, Mark. Good morning and good evening, everyone. And what we're going to talk about really is the frontline worker safety and the supply chain perspective. In addition to what Dr. Maldonado talked about in terms of the epidemiology, what I'm going to provide is a little bit of background in terms of how we are governed from a Stanford healthcare perspective and healthcare within the United States for personal protective equipment. There are federal agencies as there are state agencies that provide governance both on the use as well as, I'm sorry about this, as well as the equipment itself. And so up above, you'll see the federal agencies and you'll see the state agencies. And what drives a lot of our governance around these agencies is how we utilize them on our healthcare workers, how the equipment is regulated, as well as the public health. So all of those things are taken into consideration in addition to the epidemiology, in addition to the infection control standpoint, as we look at PPE use, what we're actually purchasing, as well as how we're utilizing them. I'm going to shift now to the conversation on the procurement and the supply chain response with COVID. And what you're seeing here is this is really a model. The U.S. healthcare supply chain performed the way that it was designed to. It's been designed as a just-in-time inventory model. For years, we've been operating a lean just-in-time inventory. And you see that here in the pre-pandemic era where you see that our inventory on hand and our utilization rates are very close. And prior to the pandemic, for example, Stanford Healthcare, and this is an example of N95s, would carry about 6 days of inventory on hand. And our reliance of inventory really came from our distribution partners. And so whether that's the Cardinals, the Owens & Minor, the Medlines of the world, that's where a lot of hospitals relied on, and that's how Stanford Healthcare operated. When the pandemic hit, the demand went overnight substantially. So for N95s, our demand went up by 400%. Not only were we competing for the regulated products by the FDA and our regulatory agencies, but we were all competing at a global level, not only for the right product, but the higher demand. This required Stanford to institute a number of immediate alternate strategies so we could keep up with the demand and build a robust supply chain, because again, the supply chain was not designed to respond to a pandemic. And so some of the ways that we did that is we looked at reuse, we looked at reprocessing. Stanford Healthcare led an initiative that allows for product exchanges all around the United States with other hospitals, so cross collaborations with our colleagues and partners. We established new products. Product innovation was a big component of the work that we did, making our own PPE and or innovating and partnering with others. And as we have progressed over the months, we continue to increase those channels and increase the funnel per se with direct suppliers, with international sourcing, with product exchanges. And what we'll call the new normal is you'll see that the gap in the supply chain model has adjusted, where we now have a significant amount of much more inventory on hand than the just-in-time model. And so for Stanford, for example, on average, we'll have about 90 days of inventory on hand at pandemic usage levels to allow for fluctuations, to allow for the demand and supply to adjust. But fundamentally, what it's required is it's required a different supply chain. One of the important things that was important for us to do is understand what we're using, where we're using it, and why we're using it. So we established dynamic PPE reporting. This was not very common prior to the pandemic. One of the first things that we had to do is we had hundreds of different types of supplies, whether they ranged from 10 different types of masks or 10 different types of gloves. We had to understand our inventory and categorize them and understand the clinical efficacy as well as the preference. And so creating the categorization and then understanding what inventory we have on hand. In order to do that, we moved into an asset inventory model. Again, another supply chain model that allows for visibility and inventory real time. So as if you're going to the grocery store, you credit or you debit your transaction, we have that information now so we can establish what the burn rate was. And the burn rate is the inventory that we utilize to understand if we increased our patients or we increased over here, that we would ensure that we had enough inventory. The other important thing that we had to do is, while every organization was competing with a limited supply market, was understanding what's the market confidence for this product. Who are our suppliers, either internationally or locally, and what is the likelihood of getting those products, and then the quality of the products coming in. And so that's where we establish market confidence. And so what you're looking at is a visual pictorial of the different ways of which we looked at PPE and monitored it. The first part was how we increased the funnel, and this is really about the active monitoring. As we think about the supply chain and the healthcare worker safety components and beyond the pandemic, it's important that we understand supply risk, and we stratify supply risk. And so what you're viewing now is actually a model that's by McKinsey & Company that's been adjusted and tailored for Stanford Healthcare and Stanford Medicine. And it talks about all different types of supply risk. And supply risk could be something very small or something significant. In 2019 alone, Resolink, which is an artificial intelligence supply chain technology company that looks at supply disruptions around the countries and around the nation, has documented there's been over 4,000 supply risks and supply disruptions that have occurred in a single year alone. And so, and what we also know is that year over year, supply disruptions and supply risk are increasing. And so it's important for us to look at supply risk and stratify supply risk, both on the magnitude of the risk, as well as what's our ability to anticipate them and ensure that we have the appropriate mitigation and response structures in place. So it can be anything from a product recall to a factory disruption to a natural disaster or a pandemic. And so one of the things that we have done is really invested in the long range resiliency approach and the long range response to the supply chain beyond COVID, whether, again, it's that recall or it's a black swan event. And so designing a comprehensive resiliency program that allows us to continue our resiliency, having a framework in which we understand we're able to monitor the pipeline of the medical supply chain from raw materials to build to consumption is really important. And that agility in that response has been a key for us in ensuring the healthcare worker safety and ensuring that we're providing the right items at the right time to the healing hands that care for our patients. So this is just a brief overview of the supply chain response with COVID.
Thank you, Amanda, for a very comprehensive overview of what it takes to develop these supply chains and to measure them. Finally, we will hear from Professor Itay Shavit. Professor Shavit.
Thank you, Mark. Okay, so healthcare providers protection and PPE was a very important topic for all of us right from the beginning. And I would like to share with you two studies that we conducted and published during the first 4 months of the pandemic in Israel. Why do I want to do that? Because of two reasons, actually. These studies reflect the lack of evidence in this area, and two, I think we can show a little bit that the use of research can help us to find suitable solutions for continuing during this pandemic. And let's go right away. In 2002-2003 outbreak, the SARS outbreak, that gives us basically the knowledge and the idea that basically any aerosol generating procedures, like Bonnie mentioned before, can pose a potential risk for aerosol-based transmission. That's a major problem. There was a nice systematic review about this, and look at this picture. The whole story in my department starts here. This picture raises questions about the protection that PPE actually provides. Look at those two physicians or nurses here. What if this patient needs to be treated with intubation in the ED? Are the physicians and nurses in the ED protected from infection? So that's a question we ask ourselves. And if you look at the WHO CDC recommendations for the use of PPE against SARS-CoV-2, you'll find something a little bit confusing. For aerosol generating procedures, the recommendation state that we should use N95 respirators, eye protections, isolated gowns, and gloves, but coveralls, boots with cover, and hair covers are not part of the recommended protective clothing. So basically what happened in Israel, and to my knowledge, in most places in the world, is that emergency department personnel actually use these type of PPE without head neck cover. And if you look at the COVID-19 departments and EMS, a full cover, PPE cover is used. And we ask ourselves a question, and that was the following question. What is the protection of ED personnel wearing the recommended PPE while caring for a simulated patient with respiratory distress? So the bottom line is, does theory meet practice? And what we actually did, together with our colleagues from the Infectious Control Service and the Pediatric Infectious Disease Unit, we did two scenarios in which we use high fidelity mannequins. In few words, high fidelity mannequins means that the mannequin breathe, talk, and cough, and we can use vital signs accordingly. And so we have a simulation here. And in situ simulation, that's the term that we use, in which we use the real environment. That's a real ED shock room. We use the teamwork work under pressure, and there's video recording. it all looks normal to them. The nice thing that we added here is we also simulated cough. And I'm not going to get into all the details here, but basically we use a fluorescent compound that is not visible when you do the training. When you practice the simulation, you don't see it. If you use ultraviolet light, you'll see something like that. That's the aerosol, the small droplets, the large droplets that you don't see when you work with the patient. And what we did actually, and basically what we also did is we used the Glogem, this fluorescent compound on predetermined surface areas of the mannequin. And then what we looked at is after completion of the simulation and before doffing, we wanted to see if the fluorescent material will be found on participants' body, specifically on exposed skin. And what we found is that all participants had markers, fluorescent markers, all over their exposed skin of head and neck. And you can see it here, which means that the bottom line is that the WHO CDC recommendations for PPE may not be fully prevent exposure in ED settings, and that the protection of the ED staff during tracheal intubation using the recommended PPE is probably suboptimal. That doesn't mean that it put us in high risk, but it means that it's not perfect. By the way, it also means that the physician or the nurse himself or herself becomes a source of infection, because when she go out of the shock room to treat other patients, they can be infected from her stethoscope or whatever, potentially, obviously. And then we went to the next step, and I think Mickey mentioned that before, and then we actually advised to use this head neck cover. We call it hijab, doesn't matter. And that type's made in Israel. We were really worried that we won't have enough stuff for the next ongoing pandemic. And since during the pandemic, there was an acute shortage in standard PPE, we actually looked for other ways to test the performance of an alternative PPE comprised of new material. So we went to the next step and we did another study. And in searching for this alternative PPE, in Israel, there was a considerable effort to find a new fabric. In this effort, there was the IDF, the army was involved, other units, intelligent units, and there was a chaos, basically. And everybody was looking for alternatives for PPE. The bottom line is that right now, I don't think that it's a major problem, but then on April, it was a threat. And so the question we ask ourselves is that the new alternative PPE will be suitable for clinical use. And then what we did basically is we used the same method of high fidelity mannequin and in situ simulation. And you can see here, we used the teams that really worked in the COVID-19 departments to be trained. They came to the shock room, and you can see that we actually test new alternative PPE. That's the standard PPE made of Tyvek, the usual one. And after the full session, we asked them, and you can see here, by the way, that's the head neck cover that we used, was tested as well. And you can see here the fluorescent markers on the provider. Not gonna get into too much details, but what we did is a crossover study, and each team used different personal protective clothing, and they switched it. And after that, we asked them to complete a Likert scale, in which they were asked to measure, to mention from 1 to 5 their satisfaction with donning, with doffing, and with management of the patient. And so we could actually compare the Tyvek, the standard one, with the new one. And that's it. And you can see here an example. And the bottom line is that we use this method to approve new material for PPE. That's it. Thank you very much. That's what I wanted to share with you.
Thank you so much, Professor Shavit. In the last minute we have, I do have one question, probably mostly for Amanda. We had a lot of difficulties, especially early on when borders were closed, in getting the products that we typically get sourced from overseas. Do you anticipate that in the long term that we will source more of our supplies locally than we have in the past? Or do you think that we'll return kind of to our older supply chain model?
Yeah, Mark, that's an excellent question. I'll say we're already seeing a lot of US-based manufacturing starting to pop up. We're seeing announcements of companies that are merging. We're getting our suppliers are going to hospitals actively saying, will you sign a 5-year commitment to buy product here if we make it here? And so I do think there will be a shift. I think it will also be important that we balance that shift. I think the key piece that we continue to lack as a healthcare industry is the true visibility of the supply chain from raw material availability to consumption. And so I think we're also going to see a lot more investment on the data and analytics side, as we are going to see more investments on the US-based manufacturing.
No, thanks so much. Appreciate that. And thank you all so much to our panelists.